what's up everybody? We are back with another Unpimpable Med video. In this video I wanted to discuss kind of the framework that you can use in order to present patients to your preceptor in the hospital. So remember, I'm talking about this from the standpoint of internal medicine. There's going to be a lot of different opinions about this. There's going to be a lot of different kind of preferences that you'll run into from preceptors, even across different specialties. In internal medicine, presentation is nothing like a surgical presentation. So just keep that in mind as you go through some of these rotations. This format that I'm going to give you that has got me really good feedback from my preceptors in my internal medicine rotations is going to get you absolutely destroyed on a surgical rotation. So I just wanted to use that as a caveat because they're very different. But I want to talk a little bit about the form of how you're going to present to your preceptor for a new patient versus a patient that you're following up on the next day. So first thing I want to talk about, and nothing that I say in this video is really going to be revolutionary by any means. I think this is all stuff that people know, but even as I've gone through rotations and gone from third to fourth year, I've noticed a huge improvement in myself, and seeing other third year med students kind of struggle with some of their formatting and stuff like that. I wanted to kind of give some tools that I've used in order to really, get great feedback about my presentations across all of my internal medicine rotations. So what I want to start with is a new patient. So you have a patient that you get assigned in the hospital, and you're going to be maybe not necessarily the first person to go see that patient, but there's no note written. All you have is their prior history from previous notes, etc. You do your chart review, and you're going to go maybe see them in the ER, or maybe they've been brought up to the floor already if you're having a busy shift, whatever it might be. So the format that you're going to use in order to blow your preceptors away is as follows. So the first thing you want to do is obviously introduce the patient with their demographics. So this is a 57-year-old female with past medical history of X, Y, and Z. Now, that's one of those pieces that's going to be different for lots of different preceptors. Some preceptors really like to have some pertinent past medical history in order to kind of build a framework of like, what is this patient's kind of chronic conditions, and are they going to be severely sick if they stay here in the hospital versus they don't have any past medical history and they just happen to get a pneumonia or whatever it might be. I think personally I've used the format of age, sex, pertinent past medical history to the case in all of my rotations, and no one has really swayed me from that. And I think it's a good practice to have because it does paint a good picture, and it's also great for calling consults. So if you're calling a specialist and you lay out, here's what the pertinent past medical history is for this patient, it kind of gives them an idea, like I said previously, of how sick is this patient, right? Same thing with like surgical history and prior treatments, like if they've been on chemo for cancer or something like that, you maybe want to throw that in your one-liner as like the introduction to this presentation. Then following that, after you give like a one-liner introduction to this patient, you want to say chief complaint, and then you want to go through all of your old carts. So you want to try to get as many of those old carts things as you can in order to, one, as you kind of get through medical education, you'll realize that they're required for billing, but two, it really helps your preceptor understand what's going on with the patient and helps them see that you really put in the effort to be thorough with your evaluation. So try to hit all those old carts things. For those that don't know, I did talk about this in a prior video, but old carts is onset, location, duration, characteristics, alleviating, aggravating factors, associated symptoms, and then radiation timing and severity. Now, a quick caveat with that, there are some things in medicine where there is no radiation or there is no timing, and you don't necessarily need to ask a patient every time, tell me, is this a 4 out of 10 pain or a 10 out of 10 pain, blah, 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 right? You can clarify it by saying like, oh, this is severe pain or this is moderate pain for the past 3 days, et cetera, et cetera. If you go through a presentation and you're saying like, and you're being really rigid with your presentation, like, okay, the onset was 2 days ago, the location is X, Y, and Z, I think that's fine, but it makes you sound very robotic. If you want it to be a very conversational type presentation, which I think is a better approach, you wouldn't go through and say, well, there's no radiation and the timing is unknown. Like if those things aren't there and they're not pertinent to whatever the chief complaint is, don't bother mentioning it, just skip past it. And I think the preceptors really appreciate that because it doesn't waste any time. So after you get through all of that, that's your whole HPI section, right? Now, the next part that I'm going to talk about is also another thing that's going to vary from person to person, but generally I've seen that people like to have your ROS after your HPI because it just makes more sense. And personally, I think it makes more sense too, because if you think about it, you just talked about all the problems that this person is coming in with and what they're describing to you. Your ROS is a way to kind of pull all of the systems together to see what the possible diagnosis could be, and it will guide your initial evaluation and potentially your treatment in the future. And I think if you go from HPI straight into kind of more of this past history before you go back to the ROS, it doesn't really feel very cohesive and it kind of can be confusing. So I would go ROS right after the HPI, and I've done this in all of my rotations and gotten good feedback about it, so take that as you will. In the way that you want to approach an ROS, so for billing purposes, you have to have 10 total systems in your ROS. Now, a lot of the times, this is just a template that people will use, and people will ask questions of the patient, and if they don't have anything that really is sticking out to them, they'll just use the template of like, pan negative ROS. But as you're interviewing a patient, you want to go through and try to get 2 items from each system. And the way that I try to keep it organized in my head, kind of regardless of what the complaint is, I'll just go head to toe, so starting with like neurologic complaints, are you having any headaches, are you having any vision changes, and then kind of going to the throat, are you having any trouble swallowing, are you having any changes in your speech, and then kind of working your way down, palpitations, chest pain, blah, blah, blah. And you can work your way from head to toe and try to get 2 things from each system for a total of 10 systems. That will be important for billing, and it also shows the kind of thoroughness of your evaluation, as I mentioned earlier. Now, if you have a pan-negative ROS. You don't need to go through and list all 20 of those things, right? That's just a giant waste of time. Just say ROS was non-contributory, there was no other associated symptoms, something like that. Have like a phrase that you go to for that. Or if you have just a couple of things that were positive and you find that they might be pertinent to the case, then just say, oh, well, this person also has chest pain, this person also is having abdominal pain and nausea, or whatever it might be, right? So just point out the things that are positive and pertinent. And then if it's completely negative, just say everything I asked about in the ROS was negative. There's nothing else, that's pertinent to the case, and move on. Next up, past medical history. So past medical history is going to be an expansion, using this format, an expansion on all of the chronic conditions this person has. So in the HPI, you listed demographics, and then you had kind of pertinent past medical history to the case, right? So like if somebody's coming in with chest pain, you want to know, oh, they also have AFib. You would put that in the HPI. But maybe if they're having chest pain, you don't really know about their osteoarthritis, but you could potentially put that here in the past medical history. And with past medical history, I think it's important to ask how long have they been suffering from that disease, and what are their treatments, and you'll talk about that in the medication section as well. But you can kind of rope these two items together, the kind of past medical history and the medication usage, in order to treat those things. Another important part for past medical history in the hospital is past surgical history. So have they had any kind of resections? Do they have all their organs? Have they had their hip replaced recently and now they're here with a blood clot? Those types of things are really important. So make sure you ask, when was the surgery and what was the outcome? I think those things are important to kind of have a thorough picture of what the patient is coming in with. And then kind of like I just mentioned, you'll go into medications after that. So far we have HPI, we have ROS, we have past medical history, past surgical history, and then you'll jump into medications, the medications that they use to treat those kind of chronic conditions. And a lot of the times you might have a patient who is delirious, or a patient that's non-responsive, or whatever it might be, and they're not able to give you a whole lot. So you can get collateral from like family members or siblings, or whatever it might be. And another way to do that is like look at the medications that they're taking, and that can tell you a lot about what their conditions might be. There are some medications obviously that can be used for multiple things, like duloxetine, for an example, can be used for nerve pain, but it also can be an antidepressant. So you speculate it will, but if you're not able to get a lot of information from the patient themselves, you can find other ways to get it, and that's one of them, looking at the medications that they take. But every time a patient comes into the hospital, it's a new admission, you're going to do a medication reconciliation, and it's essentially a list of all of the home medications that they take, and that way you avoid giving them medications that might cause adverse side effects to stuff that you're going to give them in the hospital. You can put them on their home regimen so that they control their blood pressure, etc., whatever it might be that they take at home. So you want to make sure you get dose, how long have they been taking the medication for, who prescribes it, and what they take it for, because like I said, there can be some duality to some of these medications. So that's 4 things. And with every new patient, you're going to have a list of 7 things in the subjective portion of your presentation. So we're at 4. Number 5 is allergies. In the hospital, we don't really care too much about environmental allergies or food allergies. Food maybe a little bit more than environmental, just in case they have a diet. You want to make sure that they obviously don't have anaphylaxis from the food that they're getting in the hospital, but mostly medications, we want to make sure that we're not administering anything that's going to cause them to have a reaction. So understand what the allergy is. Is it nausea and vomiting? That's not really an allergy. Are they throat swelling and they pass out and then their face blows up? That's an allergy. So understand what the reaction is and what the medication is. That's number 5. Number 6 is family history. So for family history, it may seem a lot of the time, and honestly it is a lot of the time, kind of non-contributory. A lot of people don't like when you say that, though, because they just assume that you didn't ask. And for billing purposes, I've learned recently that you need at least one family history element listed when you write your notes in order for billing to go through and be billed at the highest level. So you want to just ask, like, does your family have any conditions that run in the family, like hypertension, diabetes? List a couple of like very common things and ask them about that. If the patient has a cancer, you could ask, does anybody else in the family have that cancer, etc. So just know, like, what is the diagnosis that the family member has, who's the family member, and really you only need to worry about immediate family. So father, mother, and siblings. That's it. You don't really need to ask about grandparents and stuff like that, unless it's some genetic I don't know, colon cancer or something like that. Maybe that can help you a little bit, but otherwise just focus on immediate family. It's not usually going to be the thing that gives you a lot of answers, but it is important for billing, so ask it. And then the last element, so number 7 in your subjective portion of your presentation, is the social history. In the hospital, the things we care about the most are, do you use drugs? What drugs are you taking? How often are you taking them? What form are you taking them in? Tobacco, what form are you getting it in? How often? And how long have you been using tobacco? And then alcohol, same kind of questions there. And then some other things that might help you are like occupation. So especially with like a lot of lung disease, we ask about occupation because exposure can be really important. And then especially with elderly patients, you want to ask about their support system. Do they give themselves their own medications? Do they live alone? Do they have a nurse that comes to their house 2 times a week? Do they live in assisted living, etc.? Like that kind of stuff will be important for discharge. So asking it early and having an idea of like, what things do I need to get going for this patient will be really important. And then that's the end of your subjective presentation, right? So I know I was a little long-winded there, but ultimately that should take you 2.5 minutes to get through at the longest. All right, don't dwindle on things that don't matter. Just really get through it, be efficient, have a really well organized idea of how you're going to approach these things. And that's kind of what I'm doing here, is like trying to give you just the things that you need to say out loud. Otherwise, leave it out. And if they have further questions about, oh, well, tell me more about this, and you have that written down, that's great. You can talk about it, but focus on the things that are really important that you think that the preceptor wants to hear and that are pertinent to the case, and that will help you. So that's the framework I use for the subjective section. Now, when you go to the objective section for a new patient, here's what you want to do. First thing you want to say is vitals. Vitals, people like it different ways. Generally, what I've done is I give like a range of blood pressures, especially systolic pressures. When I'm talking about that, I give a range of temperatures. If it's somebody that's coming in with like sepsis or some type of infection, we want to know how, what's their Tmax and what does it come down to with Tylenol or whatever we're giving them with the antibiotics. Is it improving? Is it getting worse, etc. So you want to give ranges for that, for the systolic blood pressures, and then especially with like cardiac disease, like AFib and things like that, they'll want to know a range of their pulse. So if they're, tachy, you want to say like, oh, they were 110 to 140s. We gave them, metoprolol or whatever, and it came down to 110s. You don't say that in this section, but ultimately you want to know like kind of the range of the pulses. So adjust how you present the vitals based on the complaint. But ultimately ranges are better than just absolute values because you're just capturing a small portion of that person's hospital stay when you're just saying one value. So ranges are always better in my opinion. But make sure you get them all. Start with vitals before you go into physical assessment. So then you get through your vitals, you're going to go through physical assessment. Make sure you're focusing mostly on the pertinent positives and the pertinent negatives. So for example, if you have somebody that's coming in with abdominal pain, you want to make sure that you're really thorough about saying what pertinent positives and negatives are. Like they have, tenderness to palpation in the right upper quadrant, negative Murphy sign. They do have some rebound tenderness in the right lower quadrant as well. Yeah, and just stick to the objective stuff for that. You don't want to say like, oh, well, they're also having nausea and blah, blah, blah. No, that's subjective. Those are things that you leave in the first section that we just talked about. Just focus on your assessment of the patient from your eyes, and really focus on negatives and positives that matter to the case. If they have a completely normal, like in that case, if it's an abdominal exam, that's really the important part, and they have a completely normal cardiorespiratory exam, you can just say that. Cardiorespiratory exam was unremarkable. And they were, no increased work of breathing, not on oxygen, lung sounds were cleared, etc. So go through that. Next, after that, you'll go into more of the objective data. So start with labs and then imaging. With labs, for a new patient, you're going to list all the values. Make sure that you have the correct name of the lab value that you're talking about. So a common mistake that you'll see is like somebody will come in with heart failure exacerbation or a new onset heart failure. And I see a lot of students say, BNP was X, Y, and Z, but it was actually a pro BNP. And there's a difference between the two. So you make sure that you know which test you're ordering and which test you're discussing because the values for a pro BNP are way different than the values for a BNP as far as heart failure goes. So that's an example. Make sure that you're familiar with the tests. If you're not, look them up, understand what they mean. Look at your fishbone diagrams. If you don't know what that is, you can Google it, but it's essentially a quick way of listing your CBC and your CMP. And a lot of preceptors want to hear it in that order. Sometimes they don't even want you to say the sodium is 140, the potassium is 3.5, blah, blah, blah. They'll just want you to do it in that order without saying it. You'll just say, okay, CMP was 140, 3.5, 110, blah, 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 and go in that order. So really get familiar with the fishbone diagrams. That's going to be important for your efficiency and for your organization. For imaging, make sure you know the name of the test that was ordered. Was it a CT angiogram or is it a CT abdomen pelvis? Is it a blah, blah, blah? What type of CT MRI was ordered? And then look at the radiology report. As a medical student, obviously looking at your own images is important, but we have such a limited understanding of what we're looking at. Even if you're like a radiology nerd, there's people that have gone through residency and have gone through fellowships and things like that to really understand this stuff. So my go-to was always to look at all of the radiology findings and then look at the summary, and then I would just essentially summarize what the summary said. So keep it real brief. There was a X, Y, and Z size mass in the right upper lobe, and keep it real brief, but efficient and has all the information that you need from the radiology report. And then you can sit down and talk about the images together if there's any question that there might be something else going on. And then the last and probably most important part of your objective section is your assessment and plan. So this is where you're going to get a lot of your brownie points, and you want to spend most of your morning when you're doing pre-rounding in internal medicine focusing on your assessment and plan. You're going to be really inefficient at doing all of this, by the way, when you first start. I remember third year, like I had 2 or 3 patients, and it would take me like 3 hours in the morning just to like have a really good and thorough evaluation and note written for the patient before we started rounding. I always wrote my notes before we started rounding because it helped my organization when I was giving my presentations like this. I don't think that's essential, but it does help, you communicate better and more efficiently. So keep that in mind. But anyway, so assessment and plan, a couple of important things. A lot of preceptors are going to ask you for a one-liner when you're done with this whole presentation, right? So essentially 5 minutes should have elapsed from starting of your HPI all the way through to the end of your imaging section. And that's all of your objective data, all your subjective data, 5 minutes tops. You're going to get into your assessment and plan section now. This is the meat and potatoes of the whole thing because this is your clinical decision-making on display. The first thing you want to do is give a one-line summary of everything that you just said, essentially. So you want to say demographics again with pertinent past medical history of, and then you want to say here complaining of chest pain. And then you want to say like some characteristics about the chest pain, for example, like, oh, this is severe 7 out of 10 radiating chest pain down the left arm that started 2 days ago, and she's now here with worsening chest pain and shortness of breath even at rest, something like that. Keep the one-liner quite literally to 1 or 2 sentences max. It should be a real quick synopsis of everything that you just talked about. After you get through that, you're going to start going into each assessment one by one. So you want to organize your assessment list based off of priority. So if a person's coming in with chest pain that sounds like they're having a heart attack, your first assessment, especially if the EKG is consistent with like STEMI, your first assessment will be STEMI. And you're going to describe a little bit about the STEMI. You're going to say, exactly what you said in your one-liner: severe radiating chest pain, shortness of breath, etc. differential diagnosis includes X, Y, and Z. Now in this case, because the STEMI is kind of shown with like troponins and your EKG is positive, you may not need to list a really long differential, but other things to consider, could be GERD, could be, I don't know, esophageal rupture, blah, 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 right? And then you're going to talk about the treatment. So what are we doing? We're going to call cardiology for a PCI. We're going to start them on a heparin drip. We're going to give them dual antiplatelet therapy, blah, blah, blah. Your Mona Bash, right? That we talked about in the chest pain schema video. So that's kind of like what your first assessment would be. And then obviously some of these patients are going to have really complicated things going on. So you're going to have multiple assessments and you'll kind of learn what your preceptor likes to hear. But at the very least, when you first present a patient, especially like third year early on in internal medicine, you want to try to have like at least 3 or 4 assessments to discuss. And so these assessments can come from anywhere. It doesn't have to be like their main complaint. Let's say chest pain, STEMI is the only thing that this person has. You look at the lab values, they have like a normocytic anemia. Okay, so you say normocytic anemia. What are we doing for that? Well, normocytic anemia can sometimes indicate that they're bleeding, right? So we could potentially do like, I don't know, some type of like CBC trending and things like that to see if it's getting worse. It could just be their baseline. You can look at their history and see like, oh, does this person always have a low hemoglobin, etc. Same thing with like electrolytes. You want to list like hypokalemia, hypernatremia, blah, blah, blah. And then at the very like bottom of your list, you'll put all of their chronic conditions and then what are their home meds they're taking and are we going to continue them? So like, if a person has heart failure and they're on Lasix BID at home, you're going to say continue Lasix BID. If they're there for like an exacerbation of Lasix, that might be one of their main complaints and you can kind of shuffle that into the top assessment. But, if they're not there and they just have heart failure and they happen to have some other disease that they're coming to the hospital with, continue their Lasix BID. This is their dose that they're, normally taking at home. And you list all their chronic conditions and that would be the end of your presentation. And that's the best way, I think, to organize that portion. So that's how I approach new patients coming into the hospital. Now, it's much simpler when you have a patient that you have seen before and you're following up. So let's say day one, you have a patient, they give you that same patient the next day, you're going to go visit that patient, and the structure of your presentation will be much different. So let's talk about that real quick. So when we're talking about follow-up patients, your HPI, instead of doing a full old carts, full rundown of their history, blah, 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 your HPI will be 2 to 3 sentences of what brought the person into the hospital, what was done yesterday, and kind of what tests or imaging or whatever it might be are they waiting for today. So you're gonna have like 2 or 3 sentences of what that looks like. So for example, like if a patient is there and they're having their anemia is getting worse and you suspect they have a GI bleed and they haven't had their colonoscopy yet, you're going to say a patient came in with rectal bleeding that had been worsening over the past couple of days to the point where they had a syncopal episode. They're now here in the hospital awaiting GI follow-up. They have a colonoscopy scheduled for Friday. He's on, PPI, BID, and we'll transfuse him at a hemoglobin less than 7, right? That would be your HPI. That would be the things that have happened so far during their stay and what the things they are waiting for. There might be some differing opinions about that, so they may just want, like, tell me what the overnight events are. And you can certainly do it that way. I do both. So I say that during my HPI, and then I go into overnight events. I say, patient had another bleeding episode overnight, and he dropped below 7, so he got a unit of blood. That's an overnight event. You talk to the nurses, you talk to the patient, you look at the notes to kind of figure those things out. And then you'll finish your kind of subjective portion for this by saying, how is the patient doing today? And that's when you'll talk to the patient, say, how are you feeling? Are you feeling improved? Have you noticed anything different, etc. You'll do your full kind of evaluation, and you'll say, patient's doing well today, no new complaints, overall feeling better than on admission, or whatever it might be. Then your subjective portion is over there. You'll move into the objective portion. The first part, again, always the vitals. Again, do trends. Make sure that you have ranges for everything. What's the min? What's the max? What are they normally at? Kind of, median area. And then you'll talk about the physical exam, especially focusing on things that have changed or things that you noticed today that you might not have noticed yesterday. That could maybe give you some clues or, tell you if the patient's having a reaction to a medication that you're giving them or if they're getting worse, etc. So focus on those things. And then you'll do labs and imaging again. Now, a very important piece to this, when you're doing a follow-up patient, you don't go back and relist all of your labs and all of your imaging that you've done in the past days. You just focus on the new stuff. So if the patient came in and they had a CT angiogram for their PE when they came in, you don't need to relist, oh, there was a PE found on their CT angiogram. That doesn't help. If there's no new imaging, there's no new imaging. You just say that. For labs, a lot of time we trend like CBC, CMPs, or BMPs while we're in the hospital, so you'll list those. And then any new lab results that maybe they ordered yesterday that just came in today, you'll list those as well. But you don't need to go back and say, oh, a patient was, had a hemoglobin of 10 when they came in and blah, blah, blah. Like, you just need to focus on the stuff that happened overnight and today, okay? And then that ends the objective portion, very brief. This all should take like 2 minutes, 2.5 minutes. And then you get into your assessment and plan, and very similar to what we just talked about with a new patient. But now with all of your data that you've collected, with your imaging and your labs and your assessments and things like that, the order of importance of some of these things might shift. So something that was number 3 on your list of assessments might now be bumped up to number 1 because that actually is now more important than number 3. Names of things might change. So like maybe originally you thought this was a heart failure exacerbation, but maybe, their pulmonary edema or something is coming from something else. And now you have a really clear idea of what that might be. So you can change the name of that. And then you really want to make sure that you highlight, you don't need to go back through and like list all the chronic stuff and whatnot. That's only for new patients. So these assessments and plans should be like top 3 things. Here's what we're doing for them. Focus on what are we doing today that's different than yesterday that we're trying to help this patient with. And really focusing on every day having one of your own ideas. I think it's really easy to get stuck in the trap of just like copying down a note from the previous day, or copying down a note of like maybe your resident already saw this patient and now you're going to see them and they wrote a note and you're just like copying down their assessment plan. That's not good for learning, honestly. And it's okay to make mistakes. I think a lot of the time you are going to not have a complete picture of what's going on because you're not plugged in with iMobile or using the phone to contact the nurses all the time. You're not plugged in nearly as much as the residents are. So they're always going to know more information than you will. So there's no sense in just copying down somebody's assessment plan because it might change throughout the day. And then by the time you're giving your presentation, whatever they had this morning is completely different than what is actually going on. So you need to really sit down and think and try to contribute at least one novel idea to each assessment so that they can kind of see that, you're putting the effort in and that you're really thinking about these things. And make sure, I'll finish on this. Every time that you have an assessment or an idea, you have a reason that you're suggesting that idea. You can't just go in and say, oh, I want to do this imaging study, because the first question they're going to ask you is, okay, why? And if you don't have an answer for that, and if you don't, have a clear clinical reason as to why you're ordering something, they're just going to be like, okay, so you didn't think about this at all. You're just giving me buzzwords. That's a quick way to kind of get on the shit list. So keep that in mind. That's my framework for new patients and follow-up patients in the hospital. Very simple, and it works really well. Preceptors like it. It's efficient. It's straight to the point. Yes, there will be times that you miss stuff, and that's okay. But overall, this framework works very well. So try to use it. Let me know what you think. If there's other people that have different ideas, different structures that they like, please leave it in the comments. I'd love to hear. And feel free to drop a follow if you like this content. And look forward to talking to you guys more. Thank you. Bye.